Our next session will be done by Dr. Charles Samuels, MD. This is all on sleep and human performance. Now, Dr. Samuels, he's the owner of a medical director of the Center for Sleep and Human Performance, and he's got a special interest in disorders of sleep, fatigue, and obesity. The session is going to review the basic science of sleep, the function of sleep for restoration and metabolism. Specific cases of sleep disruption disorders will be presented, and the approach to treatment will be reviewed. And we're going to have lots of questions in this, so get your thinking caps on. There's going to be plenty of time to go to questions to address specific concerns that you may have with regards to sleep and training and how to apply it in your practices and lives. So everyone, please welcome Dr. Charles Samuels.
Thank you. You're up till 2 o'clock. Thank you very much, guys. I'm going to, it's a fairly small group, so if you want to come forward, I'm going to get you to ask questions and interact and whatnot. My goal here is to have you go away from the session with concrete information that you can take back to your practices, whether you're a trainer, a physio, a chiro. You see these things every day, and you see where sleep affects people's functioning during the day, their ability to recover from injury, which is probably the most prominent thing. And I'm going to go through the science of sleep and make it, have it make sense to you so that you can start to sort out the problems you actually see every day in your work. So you have this in the outline and in the handout, so basically I'm not going to go over too much in the general purpose. The outline's more important. I'm going to start by, this is the most important thing you're going to get out of the talk because it gives you the answers to everything that you see when you're clinically working with patients or with athletes. I'll talk about what happens to human performance when we affect sleep and what the link is between the two. And then I'll briefly talk about the relationship of metabolism to sleep, and that's my interest in terms of obesity and what's the relationship between weight control and sleep, because that's becoming well understood now in the last 10 years. I have 3 cases that I think are probably the most important to go over in terms of giving you examples, and then I want to leave a fair bit of time to questions, and I'm quite happy to sit around afterwards and talk about specific circumstances or cases that you might have. So I'm going to give you a basic understanding of the science of sleep. I want to give you, more importantly, the skills to incorporate that knowledge into your daily practice. So I want you to go back to the clinic tomorrow or wherever you work and have something you can use that's different than today. And then I want to give you an idea of what might be happening in an individual's sleep that could be a barrier to them progressing in their training or with weight control or with other issues that you might be seeing as well. There are some basic principles you have to understand, and there's a lot of misinformation floating around out there about different aspects of sleep, and I want to clarify them very much for you so you're better informed. Sleep is a function of the quantity, the amount. Good sleep depends on an amount of sleep. It also depends on the quality, so you can have the right amount of sleep but have a poor quality sleep, and the outcome will be negative. This is very important and very poorly understood by physicians in general, most healthcare practitioners. The circadian timing of sleep is the last thing that makes your sleep high quality. And then finally, primary sleep disorders. You may have an actual sleep disorder, something going on during your sleep that you're not aware of that is affecting the quality of the sleep. So let me ask you as a group, how many hours of sleep do you think a human needs to be able to function normally the next day? Anybody? 8.5? Okay. 6 to 7. Somebody said 4. 4, okay. How many people do you know, sir, who get 4 hours of sleep a night do really well the next day? Besides yourself? Very few. But you do, right? Okay, all right. So the range has been well studied, and this is in average individuals, so it's been well studied, and the average requirement is 6 to 8 hours of sleep. And there will always be outliers on either end of the curve. How many of you know people who really do need 9 hours of sleep a night? Yeah, okay. How many of you know people who do well, not just get, but do well on 5 hours of sleep a night every night? Okay, a few, okay. And so those would be outliers. So it's important to understand that when you're evaluating your athletes or your patients or your clients, you want to know how much sleep they need to feel good. In our society, do we get enough sleep? No. About how many hours a night are we down on average, would you say? Pardon? 1 to 1.5 hours per night over the last century. For what reason? Why have we lost sleep in the last 100 years? The light. So this is very important because it's our environment that's going to affect one of the primary things. So we're all living a life of going to work at what time? What time do we have to get up to go to work? What time do you get up to go to work? Okay. And so it's pretty early. And it doesn't allow you time to get enough sleep. And you're going to see how that impacts aspects of your sleep, because you're not allowed to finish your sleep, depending on what kind of sleep phase you have. The sleep quality, this is a very simple principle. How many of you either experience this or know someone who sleeps but wakes up unrested? Raise your hand. Pretty common, eh? Okay, that's abnormal. Sleep is supposed to be restorative. So it's very important to understand that if they have the impression or the perception that they sleep and yet they wake up unrested, that is not normal. So there has to be something going on that needs to be looked into. And it could simply be pain. It could be shoulder pain. And they're not aware that it's disrupting the quality of their sleep. The circadian timing of sleep, how many people in the room are night owls? They love to be up at night. Okay. So, can I ask you some questions? Do you mind? No, you sure? Okay. I won't embarrass you, I promise. Okay. What's it like to wake you up at 7 in the morning? Okay, but do you feel good at 7? Okay, so who's a night owl who feels like hell at 7 in the morning? Yeah, okay. All right, that's normal for a real night owl. For a real night owl who has a delayed sleep phase, if you wake them up at 7, that's almost right in the middle of their brain sleep. They don't like that. And of course you have to, because you got to go to work, right? Unless you're a shift worker. No. Okay? So this is sleep phase. And most people in this room will have a delayed sleep phase, not an advanced sleep phase, where they have to go to bed at 8 every night. Who has to go to bed at 8 every night? Who in your practices goes to bed at 8? Older people. Okay? And there's a whole bunch of reasons why they shift to an advanced sleep phase as they age. And it has to do with core body temperature. But the sleep phase is very important. And for instance, this is something that I'm doing with the Canadian Olympic speed skating team in Calgary, is we're working on figuring out the profile for each athlete for their training to get them into their sleep phase, because they're sleeping against their phase. Some of the kids are night owls, some of them are larks. And if you get a night owl up at 7 and train them, that's not a good idea. There's a whole host of reasons why, and it's actually been studied. The neurohumoral changes have been studied in those athletes, and you see differences, and you'll get more as we go along. But that sleep phase is very important. If you can figure that out for the athlete, you can help them time their training, which is something that we're looking at doing. An example of a primary sleep disorder, snoring. People think snoring is normal. The prevalence of obstructive sleep apnea in professional football players is twice that of the average population because of the size of their necks. And obstructive sleep apnea is very disruptive to sleep. Okay? It creates a great hyper-aroused state, which you like in a lineman, because you want them to be very angry. So, you know. So the basics of sleep are this. There are 3 processes. If you walk out of the room knowing this, you'll be very well educated, actually. Better educated than a first-year medical school class. The homeostatic process is the first thing that drives your brain to sleep. Okay? The circadian process is the circadian timing. Okay, when does your brain sleep? And it's individual and genetically predetermined. Don't you guys have notes? Didn't you get handouts? Okay. You don't have to write notes. It's for fun. And the ultradian process is that process that goes on in the brain. What's happening in the brain as you sleep through a night? Okay? So the homeostatic process is this. It regulates the balance between sleep and waking. You are now, at this very minute, accumulating sleep debt for sleep tonight. If you were sleeping now, you would not be accumulating sleep debt, and you would have more difficulty, generally speaking, falling asleep tonight. And that's every 24 hours. So you accumulate sleep debt. And the neurobiology of it is that adenosine is now starting to rise in your brain. That's what we now know is the sleep hormone, we believe, during the day, that drives the pressure to sleep. That sleepiness you get at 11 o'clock at night is a buildup of adenosine. And that's what coffee mitigates. So the mechanism of caffeine is to inhibit adenosine buildup during the day. Okay, and we used to believe it was a methylxanthine inhibitor, but it's not. And that's just in the last 5 to 10 years that that's been looked at. So the need for sleep is determined by the amount and quality of the sleep in the preceding sleep period. Professional hockey players, 80 games a season. Brutal life with absolutely no attention to how much chronic sleep disruption, not necessarily debt, but disruption, because these guys are flying across the country, okay, more than 4 time zones, okay, and at the same time they're playing late, which severely disrupts the quality of the sleep they get at night, and then they're training and whatnot. And so there's a lot that goes on. That's a very good example of where the quality of the sleep is very poor. And this is essentially sleep debt. And you accumulate sleep debt on a 24-hour basis every 24 hours. Okay? So keep in mind that the day and night are linked. What happens in your brain during waking affects your sleep. This is very important to understand. And you can start to make sense of some of the behaviors that your patients or clients have and why they might be inhibiting their ability to sleep at night or making their sleep poor. The circadian process is that process in the brain that regulates the timing of wakefulness and sleepiness during the 24-hour day, because we have a rhythm throughout the 24-hour days. It is not normal to be fully alert from 7 in the morning till 10 at night. That's abnormal. You're taking drugs. Something's wrong, okay? Because that's abnormal. And people, of course, want that, right? So what's the classic time during the day when people are tired? Anybody?
Is that when you get the most peaceful sleep at night?
No, during the day. What's the classic time during the day in waking when you're tired? After lunch, right? And it's the food, right? Nope. Okay, it's the circadian low in the day. And you'll see how this comes out. So it's very important to understand that has nothing to do with food. You can impact that. You can make it worse by the way you eat. If you tend to eat a very high carbohydrate intake at lunch, people will tell you they feel more tired. Okay? If you're chronically sleep deprived, that low in the middle of the day is brutal. If you're well rested, that low is not as bad. Usually people will have a half an hour low, somewhere between 2 and 4, or 1 and 3, depending on your circadian phase. And they'll come out of it and they'll feel fine for the rest of the day until bedtime. And it's controlled. Your circadian process is controlled by exposure to light, outside light, in the morning. This is critical because we live in Canada. We don't get that for about 6 months a year, especially if you're up at 6 o'clock going to work, right? So we're missing what's called a Zeitgeber, or a cue, every day, a daily cue that the brain requires. Now, some people are genetically more resistant to this than others. So some people can tolerate circadian miscuing, and it doesn't bother them. They make great shift workers. But most people, they feel that. And through the winter, as you know, there's seasonal affective disorder, which is a circadian-based mood disorder. Okay? And you see this, where it's very prevalent in Canada. And people just get more tired and want to hibernate. They get that sense of hibernating. Their appetite changes as a function of fatigue. And so there's a lot of these things that are linked together. And this is controlled by exposure to light in the morning. Okay? And it has to be outside. It's not the corner office with the windows on the east side. Doesn't cut it. Okay? Or the nook. You know, I built my house so that it's east-facing the nook. Okay? So that's why we have SAD lights, these special winter depression lights. So you got to get light in the eye, straight back to the retina, and then to the SCN to control the secretion and suppression of melatonin. So the ultradian process is what's going on in the brain. Now, people have a very misconstrued understanding of what sleep stages are, so I want you to get this, ask questions if you think something's different or you've been told something else. But the sleep stages are determined by the electroencephalogram of the individual during sleep. So it's the brain waves. And remember that that's an electrophysiological representation of a phenomena. So it's a picture of what we believe is going on. That's all. It's nothing more than that. So stages 1 through 4 are non-REM sleep. That's the way we classify it. REM, non-REM. That's it. Stages 1 and 2 are light sleep, and you drift into them as you're entering into your sleep state. How many of you have nodded off in the car driving? Raise your hands. Yeah, there's probably more of you. Okay, you've just fallen asleep. That's stage 1. So you were asleep, and that's a micro sleep of 3 seconds where you wake yourself up. So if we have the EEG on you, we can watch you just drift right into sleep. Okay? Stages 3 and 4 are deep, slow wave sleep. Okay? And so there are certain functions that occur in slow wave sleep, certain functions that occur in light sleep, and then certain functions that occur in REM sleep. And that's what's important to us, because that's what tells us what's happening with the individual and how sleep might be related to what you're seeing. So the sleep stage functions are non-REM sleep is believed to be restorative, so physically restorative. There's numerous things that go on. And REM sleep is believed to be most important for memory consolidation. From our point of view, when we're studying people, REM is a very different state cardiovascularly. It's a very unstable state. Cardiac arrhythmias occur in that state, for instance. And non-REM sleep is a very stable state physiologically. Okay, your breathing, cardiovascular system are all quite stable. Okay? But how many of you had a nap and woke up and felt terrible? Okay, so that is waking up. That nap usually was beyond 30 minutes, usually. Okay? And if you have a shorter nap, it tends to be more refreshing. So if you've had a 30-minute nap, do you tend to be refreshed, would you say? Okay, and then you think, oh, I'll get an hour and I'll feel even better, right? And then you feel terrible. And that's because you've woken up out of stages 3 and 4 of sleep, and that's not fun. That feels bad. So you want to keep your napping, and we do strategic napping, for instance, with the athletes and executives and whatnot, so that they get brain rest, basically, is the term, but they don't drift into stages 3 and 4, because you'll feel terrible for the rest of the day. Okay? So, this is what it looks like. You understand the stages now, 1, 2, 3, and 4, and the picture is across a night of sleep, 8 hours. This is a typical, normal, healthy adult. They descend from stage 1 to stage 4 and then back up to REM every 60 to 90 minutes. So how many of you in the room wake up routinely at the same time every night? Okay, there's a reason. First of all, those people who have awakenings through the night that are quite routine have a higher state of arousal in their sleep, so they don't sleep deeply in general, okay? And You are fragile right here. Every 60 to 90 minutes, you have an arousal. So people who are more hyper-aroused will tend to wake up, whereas everyone else will just roll over and go back to sleep. So the very important thing for you guys to understand is that this is a process. Every 60 to 90 minutes, the same thing goes over and over and over. And that'll tell you why a lot of things are happening to people in the middle of the night, because you have a fragile period. The other thing is that in the first 3 hours of the night, you get most of your slow wave sleep. And for instance, one thing that happens during slow wave sleep is growth hormone secretion, which, you know, the athletes are all hyped up on growth hormone. It's a big deal. Well, this is where it's secreted, again, most potently in younger athletes. It's the response is dampened as we age. Okay? So disrupting that first 3 to 4 hours of sleep can have an impact physiologically. So you want to have a good period of sleep here. And are there any shift workers in the group? Wow. Shift workers will tell you when they come off nights, they get 4 hours, and then they can't sleep after that, the bad ones. Okay? And that's because they're so sleep deprived, your brain just goes straight into slow wave sleep very quickly when you're sleep deprived. Okay? So it'll just charge right into slow wave sleep. And you notice that in the last 2/3 of the night, you get more light sleep, but also more REM. So if you cut off your last 2 hours of sleep, if your sleep phase is a sleep phase of midnight to 8, and you wake up at 6, you've lost 2 hours. And what you're losing is you're getting chronically REM deprived. And that will have an outcome from a cognitive perspective. So this is important stuff. So I'm going to stop there and see if you have any questions before we go on. Any questions about that stuff? Queries?
Yeah, can you comment more on growth hormone and the number of spikes at what times?
You're going to have to be more clear about what you want me to comment on.
So I have the impression that growth hormone was released, but was this anything that had to do with being released during each of those phases, as opposed to just the first 3 to 4 hours?
And what difference would that make to you?
Knowing that. I don't know, it's verifying something.
So it's pulsatile secretion of growth hormone through those stages, absolutely. Yeah, and it's pulsatile. But the bottom line is that that is the zone in sleep when it is secreted.
The last time, always the first.
In terms of slow wave sleep, no. It's secreted during stages of slow wave sleep. And you have slow wave sleep at the end of your sleep, just very brief periods though. Right, so the dominant time of slow wave sleep is in the first 3 hours usually. Keeping in mind that you should be in your sleep phase.
In mind, some the sleep you don't get before midnight, you don't get it at that time.
I'm not sure what you mean. Yeah.
What I mean is, I'm not unlike others, that you could go to bed early, but you could never sleep.
Right, okay.
You get to sleep early in the night, but you could never get it at all.
But are you finishing a 7 to 8 hour sleep period? Are you? Okay, so the question is, and I'll paraphrase it, about the blocks of sleep. Guys, the bottom line is people need 7 to 8 hours of sleep. So just, that's it. That's the rule, that's the end, enough. So people who have difficulty finishing their sleep, we have to help them. So and you'll have many athletes or people you work with who have awakenings in the middle of the night and very poor quality sleep thereafter. Well, they need help because you want them to finish their sleep. And you know, this is what we do. We help them do that. So it's important to get all your sleep. As far as the growth hormone question goes, it is secreted during stages 3 and 4, which are mostly at the beginning of the night. Anything else?
Yes. You were saying sunlight through the window is not good, you have to address it.
Right. Yes. So the dose of light required, this is the question, light through the window doesn't change the biological clock. Just so you understand, the suprachiasmatic nucleus in the brainstem, is the clock, the biological clock. And it tells the pineal gland to release melatonin. Melatonin is released at the beginning of your sleep phase and peaks in in the middle of your sleep phase. The only intervention that has been shown to suppress melatonin, which makes sense in the brain, is light exposure at 10,000 lux in a 450 to 550 nanometer range, blue light, which you can't get through a window. So we have the artificial lights, the SAD lights that we use in Canada because it gives you the dose, or you go outside. Yes?
Does that affect someone who's blind?
Well, that's a very good question, but I'm not going to answer it, okay? Yes, in the red coat.
How do these numbers reflect when you're dealing with teenagers, i.e. the quantity?
Totally different. So I'm going to give you one thing that's good. There's always the teenage thing. How many hours of sleep does a teenager need? 10 hours a night. So with the young athletes, I have a case here because they're classic. They're not getting enough sleep. So I'm going to just sort of shut it down and move on. Go ahead, one last one.
What about glasses or contact lenses?
Well, no. Like glasses, you're going to get light through. So that's okay. But I do tell people who are going outside, no contacts, no glasses. It's 30 minutes. It's not a big deal. I usually get if they can, go for a walk. If not, we use the light in the patients who need it, right? So the summation of all of this is in this slide. You have homeostatic drive, which we now know is linked to adenosine secretion, okay, just as one. And if you drink coffee, it will suppress that if you're feeling tired. And it peaks, your homeostatic drive peaks around midnight. So you're tired if you're a normal 11 to 7 person, okay? And then you recover your sleep debt through the night as you sleep, assuming you have normal sleep. Now the circadian alerting factors work in concert. So there are circadian alerting factors in your body that, in spite of homeostatic drive, still keep you alert until you're extremely sleep deprived, and then it doesn't work anymore. So again, a shift worker will tell you, I get home at 8 and I want to sleep, but I can't. That's because their circadian factors are kicking in the morning. So they have to leave work with sunglasses on to mitigate the effect of sun on melatonin, and we don't want the melatonin to be suppressed. We want them to get whatever they can, okay? And so these now meet around the evening where you've got a big sleep load, but lots of alerting factors, so you stay awake, so you feel pretty good. And then, of course, they drop off precipitously in the evening so that you can induce sleep. These things have to be coordinated. So you can see if you're sleeping out of phase, it doesn't work. And so this is the alertness line. This is what you want to know, is that normally, a normally rested individual who wakes up at 8 will start to feel alert. It takes about an hour to feel alert. So when somebody comes in and says, oh, I'm great, doc, I wake up, as soon as my feet hit the floor, I'm awake, I immediately go, something wrong here. Okay, because that's just not normal. Your brain requires time to wake up. Okay, and that's a state of hyperarousal. And a lot of doctors here are talking about this state of HPA activation. And that's what it is, a very high state of arousal. Again, you'll see this in hockey players who are drinking 3 to 4 liters of Coke a day. All right? So you have the afternoon dip here, and then you come up in the evening, and then down. And that's a normal alertness pattern in a circadian rhythm. Okay? Primary sleep disorders. So these are things that, as clinicians, for sure the chiropractor should be aware of these things. For sure. Because if you're not getting ahead and helping someone, at least ask them, how do you sleep? It's a simple question. And certainly I bet the trainers all do ask their athletes, how are you sleeping? And you want to know, because if they snore, they could have a sleep disorder. And snoring's on a spectrum of completely normal and disturbing to everyone else but the individual, right? To stopping breathing 120 times an hour with an oxygen desaturation down to 50% at night. Well, that's not good for you. And you'd be amazed at what some of these athletes, especially the power builders, you'd be amazed at how bad they have sleep apnea. Movement disorders in sleep, typically restless leg syndrome is a common one. The other one is periodic limb movement disorder, where they'll jerk their legs in sleep. Again, the chiros would see that. Okay, they would get that. Parasomnia, sleepwalking. That's a good example of a parasomnia. Okay? Circadian rhythm disorders, shift work. It's really important to find out. I know that physicians actually aren't aware of the prevalence of shift work in their practice. So you should really be asking people, do you do shift work? And we define shift work as anything outside the 8 to 5 work day, 5 days a week. It's a very restrictive definition, eh? This is not just rotating shifts of 12 hours. Okay, so anybody who's operating outside that zone will have similar but less effect, shift work effect. It's quite significant. Okay? A lot of athletes will choose shift work for training. And there's huge circadian dysrhythmia in shift work. The other things that are very common and you're all aware of are sleep hygiene issues, environmental issues, cats, dogs, children in the bed, that kind of stuff. And insufficient sleep is the most common cause of fatigue in North America. Okay, so these are just silly slides. This is classic insomnia. Okay, so then one morning I woke up and found I had nothing to worry about, and that got me worried. Okay, so this is a classic insomnia. Just a very high state of arousal and worry. They don't fit the criteria for generalized anxiety disorder, obsessive compulsive disorder, panic disorder. They don't fit into that category, but they have a very high state of arousal. And you see lots of people like that. Very jumped, the executives, those kind of people. They have a hard time winding down at the end of the day, and they have difficulty with sleep, and it starts to perpetuate itself. They start to focus on I can't sleep, and then they really can't sleep. And when people can't sleep, what do they do during the day to feel better? Drink coffee. Or what's that, Red Bull? Or something like that, you know? And man, that's not good. What's the half-life of caffeine? Anybody know? Yeah, it's about 7 to 8 hours. And these people are drinking, 14 triple lattes, I mean, they're huge, right? Or the big Tim Hortons jug, And I mean, that's a lot of caffeine. The caffeine in a typical Starbucks has been measured. A cup of coffee that you get at the hotel is 250 milligrams of caffeine, pretty typically. And the Starbucks, 400 milligrams of caffeine. That's a therapeutic dose of caffeine for a tank driver in the U.S. military. So, it's pretty potent. This is important. You have to find out if teenagers are night owls, if your teenage hockey players are night owls, if they like staying up late, because that's normal for a teen to have a delay in their sleep phase. That's normal for most teens, but some have a disorder where they're a real night owl, so it's even worse. Well, these kids, if they're playing sports and waking up at 5 or 6 to train, that is terrible for them, okay? So, it's no wonder you're tired, you're not sleeping at night, and this is so common. If you have executives who are computer geeks, engineers, those guys, they're all up until 2 o'clock in the morning. Okay, and then this. Snoring can present as insomnia. Okay. So sleep apnea can present as insomnia. So it just really, I think it's so important. It's so simple. You got to ask people if they snore. And women too, women snore. And women snore more after menopause. Okay, any questions about what we've talked about so far? Yes?
Is there a question whether consider snoring? Some people say, well, I don't snore.
I love that, eh? That's because he snores. His wife says he snores, but he says, I don't snore, right? Snoring is snoring.
So if you snore a little bit, you're snoring?
Yeah, but that might not be pathological. That could be well within normal. I mean, you got guys who are knocking the roof off. Well, they sleep 8 hours, they wake up, they feel great. Everybody hates them. But they're fine.
Has anything to do with your overweight? Is some block of weight?
So the issue with snoring is important. It's not only obesity, because, so the question was, what causes snoring? And I'll be very brief here. The assumption is that it's only obesity. It's not, because you can have very thin people with severe sleep apnea because of the shape of the jaw. So there's a factor there, and the size of the airway is very important. So when you look, I always tell family docs, if you examine the throat, because they examine throats endlessly, right? I say, examine the throat. If you say to yourself, I sure wouldn't like to intubate that patient. In other words, their tongue is huge. You can't even see their tonsils. They snore, for sure. And their airway probably closes in sleep. So you should at least ask the question.
My friend really, really skinny. Every time we look at it, it's like, oh, man.
brutal. Yeah, and does he look like Joe Clark? Okay, so anybody with a receded jawline, really receded, I always say the Joe Clark, Brian Mulrooney continuum. Okay, so that receded jawline is a clue that they're a pretty big time snorer. And athletes, we have one of the team athletes who has brutal sleep apnea, and they stuck the guy in a hypoxic tent for high altitude training. He was desaturating like to 50%. Like, that's bad for you. You know, and it's just that nobody thought he had a problem, really. He just snored and drove everyone nuts when they traveled, right? Exactly, yeah. And that's the difference when I say about non-restorative sleep. That's a pretty typical example of where people will sleep but wake up very tired and unrested and feel bad. Okay. Any other questions about it? Yep.
You said there's a range of sleep for adults, 7 to 8 hours. How do you know you're getting the optimal amount for you individual? What signs should you look for through the day?
So how do you determine the optimum sleep quantity for you or your athletes? So I would say for you, you need a 28-day period where you can let yourself, what we just say, free run and fall into your sleep zone. So it's very difficult if you have to wake up every day for work at the same time to find that out. Well, I would take 2 weeks and just let yourself figure it out. And you'll know right away, like within a week, you'll start to go, oh my God, I really need to stay up till midnight. Because you say, maybe you say, I got to go to bed by 10 because I got to get enough sleep, right? That's what people always do, right? Or you force yourself to stay up past 10 because you've got to work, or that's your only quiet time. Those are the two pretty typical situations. If you let that all go and just say, okay, I'm going to see when I feel sleepy, and then let it happen. And then the anchor for sleep is wake. The anchor for sleep is waking spontaneously. When do you wake spontaneously? Not with an alarm clock. Okay, so that's the key. And it'll be like 7 for, somewhere 7 or 8 for most people. Most humans, as we get further away from the equator, our wake time is certainly beyond 7 o'clock in the morning. And, people are getting up at 4 in the morning to go and work out. Like, that's ridiculous.
Isn't that something that you time yourself, though? Like, your own clock starts to work. After a week of getting up at 6 o'clock in the morning, you automatically get up at 6.
Oh, you can entrain yourself, yes. But you could do that. But I would argue that most people really, they don't realize that it's dysfunctional. Because you always have to ask yourself, do you feel good? If you feel good, nothing matters, right? Just keep doing it.
So how long would it take you to break that bus?
Break what?
That pattern at 7, getting up with the alarm, and, not getting up the alarm, but getting up at the same time.
So how long would it take to break the pattern? It just depends. And I always give people the 14 to 28 days to test it out. And that would be it. And I have people use sleep logs. So they see the picture, and they fill in a graph of when they're sleeping and not sleeping. And they start to get the pattern down. That's what I do with them.
How do you roll the whole? You mentioned earlier, first of all, we have a natural rhythm where we should be. If someone's old rhythm is skewed, so they're sleeping in. How do you roll it?
Correct. Okay. So the question is, how do you correct your rhythm? And the night owl is a perfect example, and we do that a lot. A night owl's rhythm is, bed at 1, and they don't realize it, but they really don't sleep well unless they're going to bed at 1 in the morning. And then they wake up at 9, let's say. That would be their normal pattern. What we do is expose them to bright light. So we use the SAD lights, and we push their brain clock backwards. That's how we do it.
First thing,
Yeah. You bet. Yeah, and then we just, I'm quite mean to people. I just say, okay, starting tomorrow, you're getting up at 7. And you sit in front of that light. And it's a very rapid response. Now, again, the response rate to light is about 60%, so it's not 100%. I'll go with this woman and then so.
So I've seen lots of people say that they really sleep better over the course of the week. Is that, not real? Or can you actually, so if you only sleep 4 or 5 hours a night all week, Friday, and you sleep from 5 o'clock until the next morning, is that because you sleep better, or is that just sort of, you just decide?
Okay, well, the question is accumulation of sleep debt, and I think your first thing was that people say that they accumulate sleep debt on a daily basis?
No, so over the course of a whole week, so they don't sleep all during the week enough, and then they think that they're compensating for that by.
Okay, so that's your question. So really your question is, can you compensate for your sleep debt? Is that right?
Do you feel that you need to sleep more because of that?
Well, you should be able to answer that after what I just said. Because the bottom line is sleep pressure. Absolutely. You accumulate sleep debt on a 24-hour period. Most of this room is accumulating on a daily basis probably 1 hour a day of sleep debt, and some are up to the 2 hours a day of sleep debt for themselves. And at the end of the week, you've accumulated 10 hours of sleep debt. You're going to be freaking tired on Saturday. Okay? And that's how it feels to live in our society right now for a lot of people. Okay, they accumulate sleep debt. Yes?
Do you have any good solutions at this time for those who snore or have sleep apnea?
Oh, yeah. Oh, there's very good treatments. And in fact, in Ontario, it's all covered by the government, unlike our poor province in Alberta. We don't have the money to cover it. So people have to pay out of their pocket. So you've got 140 sleep labs. We have 4 in the province of Alberta. So you've got very good services for the treatment of sleep disorders in this province.
Outside of CPAP? Is that
There's other treatments. There's dental appliances and there's surgery and stuff. And it just depends on the degree of apnea, because dental appliances only work in moderate to mild cases. So, yep.
What happens in the case like my employer's not going to let the start coming in at 10 o'clock every morning, or the athlete in their competition is at a certain time 1 week and another time another week? How do you adjust for those?
So that's an individual plan. How do you accommodate to your life? You have a job and you have to live it. Well, that's why people come and we help them, because we strategize a way around all of that to get the optimum, always knowing that you won't get it. Now remember, this is for people who are suffering. If you're not suffering, it doesn't matter. So a lot of people, are highly resistant to all of this sleep debt, highly resistant to the effects of sleep debt. So it's not an issue. But if you have an athlete who's crumbling under your feet, really not doing well and not recovering, those are the ones who need the real help. And for the sort of high-end people that I'll see from, the corporate world, we just strategize. We do strategic napping, light therapy, all different kinds of things.
So then what would be some of the signs then of somebody not getting that on a regular basis?
Getting enough sleep? We're about to go in there, okay? So we'll move on. That was a good segue, actually. So sleep and human performance. And I'm going to be fairly general about this because the research is unbelievable in this area. And it's a huge field, and it's driven by the US military and NASA. A phenomenal amount of research has gone into cognitive dysfunction and sleep deprivation over the last 40 years. So we know a great deal about how to keep people up really long and kill other people in fighter jets. That's what drives this kind of stuff. So the bottom line is that if you sleep deprive an individual, and I'll use this example, if you keep someone awake for 17 hours, there is a dramatic drop in cognitive function in tasks of attention. There's a variety of different tasks. The one that we use is the psychomotor vigilance test. And so that test, the performance will drop drastically at 17 hours of wakefulness. Okay? So as you sleep deprive people, their cognitive ability to track, to drive, this is tested in driving and transportation, all gets lower. To respond, all of it is impaired. And we now know that that's the equivalent of being over the legal limit of alcohol. So we have a really good comparison that sleep debt equates to being over the legal limit of alcohol. And that's actually what's finally driving hospitals and medicine and police forces to pay attention. The fatigue factor. Okay? So cognition is memory and concentration. So you'll see, these are very sensitive things that you'll start to see. A lawyer, you'll start to see, for instance, what I get is multitasking. I can't do as many things as I used to all at once. Focusing on tasks. I get distracted. In order to keep myself awake, I have to have too many things going on, and I'm making more mistakes, those kinds of things. Attention at meetings, that's simple. Afternoon meetings, I always could stay awake, but now I can't. I'm drifting off. I'm snoring in the meetings, with the partners or whatever. So the thing that you'll see in workers with sleep debt, shift workers, and in the healthcare profession, mood. There's a huge risk for depression, the development of mood disorder as you become chronically sleep deprived. And there's a very good link now between the two, and it's bidirectional. So mood disorders cause sleep disruption. Sleep disruption can cause mood disorders. It goes both ways. So that makes it very difficult. So there are huge consequences. This will come a little bit later, you can suffer a week of being sleep deprived. I mean, any mothers in the crowd? What's it like waking up in the middle of the night 15 times? What's the symptom that you would get if you were sleep deprived? What's the thing that you people would say? Top on the list. Sorry? Irritable. So that's the first thing that people notice. They're edgy and irritable. And then it progressively goes downhill from there. So those are subtle things that you'll notice as time goes on. And then as it really goes on, they start to develop physical symptoms. And very common physical symptoms are headaches, muscle pain, pain in sleep, stiffness, and that's, for the athletes, a big one. And gastrointestinal upset. Those are sort of the big blocks of symptoms that come physically that are really prominent. Harvey Moldavsky, who's from the University of Toronto here, very well-known, famous sleep researcher, took 20 high-performance athletes about 20 years ago and sleep-deprived them in the lab, and they developed fibromyalgia. So this was like the pivotal study that started work on fibromyalgia, because you could sleep disrupt a normal person who was healthy and give them the same symptoms. And it's like they stick a pin in their butt all night long or whatever. They wake them up and just really disrupt their sleep. And so there's a lot of work in this area. And so the things that come down the road will be endurance and fatigability, and that's way down the road. A lot of athletes, of course, can go forever because physically you won't be as impaired as quickly as mentally. The mental functions will drop off long before physical functions. And in medicine, skill is preserved. A surgeon's skill is relatively well preserved with severe sleep debt, 36 hours a week. But their decision-making is abysmal. So they can do the operation, it's just on the wrong person. So, strength and recovery. So recovery is the big issue here, right? I'm going to move on to the sleep and metabolism because I do want to do the cases. So there is a definite link between sleep and sleep quality and sleep length and our metabolic function. And most of you are aware of the HPA axis, growth hormone, those kinds of things, cortisol and whatnot. But what was recently studied in the late 90s and up until now, and the work is progressing at a rapid rate, is, and I'll just give you this study, it was very interesting. 20 normal, healthy adults were stuck into a lab in a chronic sleep deprivation protocol, which is 4 hours a night. But they were forced to stay in bed awake for the next 4 hours, over 10 days. And those people, after 10 days, developed a pre-diabetic state, totally normal. So their lipids were abnormal, their insulin sensitivity was abnormal, and their fasting glucoses were abnormal in total normal, healthy adults. So we know there's a link. There's something that happens when you restrict sleep that changes metabolism. More importantly, and from my point of view, they were kept awake for 4 hours in bed. So they were eucaloric. They didn't expend any energy, and their appetite went up. So we also know there's a relationship between fatigue and appetite. And all of you know that. When you get tired, people like to eat. And what do they eat? Donuts. So there's something there neurobiologically that's being worked out very well. And there's one common neurotransmitter that links the two together, and it's the orexins. And they're a relatively new neurotransmitter that was sort of brought to the sleep field into the 1999, I think. And it's work that looks at narcoleptics and obese patients, and it's the same neurotransmitter that's deficient in those conditions. And so there is a strong link. And any of you know this. If, I always say to the shift workers or the police officers, go onto the wards in the hospital in the middle of the night and see what the nurses are eating. It's all high-fat foods, and stuff, because that's what people crave. And there is a biological reason now. And so my interest is in those people and correcting those factors in the sleep factors to mitigate their appetite. You guys talk a lot at this meeting about fat and weight loss and stuff like that. One of the big things that's missed, certainly in medicine, is what drives the patient to eat. I see people who are obese and have tried, they try everything, and they say, I really am walking every day and not eating a lot. And I like to believe them. I tend to be quite a suspicious guy, but a lot of them are telling the truth. And when we start looking at the sleep and see how disrupted it is, when you correct it, it changes a lot of the factors that are barriers to weight loss. So that's the key. It's a barrier to weight loss, poor sleep. If we don't address it, you may not move forward in working with your people. That's all. And this is, and all of these things, you've heard a lot. The sympathetic tone is that state of hyperarousal. And you get a hockey player who's running on empty, and these guys are in a permanent state of arousal. They're not going to sleep well, and it just continuously exacerbates itself. And then they become cognitively stuck in a state of insomnia or poor sleep and chronic fatigue, only able to arise to the occasion of a game. That kind of thing. Yep?
That most easily corrected.
How is it most easily corrected? It's not easily corrected. It's extremely difficult to correct. And so, sorting those people out is very, very difficult.
What's the process?
That's for another day. That's a long answer. That is not an easy state when they get to that end of sorting them out. But it's important to understand that what's driving it is an incredibly high state of arousal. You guys see this, you witness it. They're edgy, agitated, they talk fast. All of these things you see, they might be sweating a lot more than normal. They're very high state of arousal. And you've heard lots of talks about cortisol. Cortisol is circadian in its release. And if you disrupt this with the sleep phase, you're disrupting a normal biological function, which reinforces the importance of finding out the athlete's sleep phase. Yep.
So you're measuring epinephrine is also epinephrine?
Well, there's sympathetic tone, so you can measure that in a variety of ways. You can do heart rate variability, you can do sural nerve testing, you can do all kinds of tests. So, it just depends. The model for this is sleep apnea. Sleep apneics are in a permanent state of high sympathetic tone, and so we learn a lot from that model about what it does to sleep. And what we know with obese apneics versus non-obese apneics, the obese apneics who go untreated have a great deal of difficulty losing weight, and a greater difficulty than the wait a minute, sorry, I got to think about this. The obese apneics are treated and non-treated for sleep apnea. If you treat an apneic and get rid of the sleep factor in an obese apneic, they'll tend to lose weight more than an obese apneic who remains untreated, is the comparison. So once you get rid of that factor, you put them in a normal state, they can then start to lose weight. Sleep and appetite is my thing. What I'm really interested in is, why do people eat? Why do they want to eat that stuff? Because I don't think it's an issue of willpower at all. I don't go there with people. They've heard it from 1,000 people before by the time they get to me. There are biological reasons why they have a taste for high-calorie dense foods and why they need high-calorie dense foods. And if you spin it that way, first of all, they have a sigh of relief because they feel terrible that they're labeled as having no willpower. And some do not have willpower. And you do have to crack them in the ass, and say, okay, wise up. But the thing is, this gives them a reason to start working again. If you can correct some of these things and they can see a sense, oh, my appetite's going down. Happens with light therapy in winter depression. You expose someone to light who has winter depression and their appetite goes down, they just love you because they can't believe that their carbohydrate cravings are gone. And it works very effectively, again, in only about 60% of patients with true winter depression. Okay, any questions? We'll go on to cases. Yes, in the back, the gentleman.
How disruptive is it to your sleep and rejuvenation when you get up in the middle of the night and urinate?
It's totally normal. How disruptive is it to get up in the middle of the night, go to the bathroom, have a 5 or 10 minute awake, and then go back to sleep? Total nothing, zero. That's normal. Yep.
What are the changes in sleep requirements of people having apnea, but this training is exhausted after training, some is overtraining?
So the question is, what do you do for the athletes who are basically overreaching or overtrained, right? And from a sleep perspective, how would you work with them? Again, that's a day in and of itself, and it's very individual. But the most important thing is that you know that overtraining can be broken down into that sympathetic, parasympathetic group. That's one classification of overtraining. And keep in mind that the sympathetic group are hyperaroused. So you have to help them reduce their hyperarousal. And so, because they'll be severely sleep disrupted from that state. So to me, the starting point, if you see what happens with these guys is we give them rest, but they don't sleep. And they get frustrated. You know, and it just goes on. So really, obviously I'm a sleep doctor, right? So I think that the cornerstone of their health is to get them sleeping well. Some of them oversleep. They're so fatigued, which is the parasympathetic side, will oversleep. Well, there's arguments for and against oversleeping. And I would do it on an individual basis. From my point of view, I can figure out if someone's sleeping too much by the way they describe what happens when they wake up and when they're sleeping. And I don't let them oversleep. That's a very bad thing. So chronic fatigue, I don't know if you work with chronic fatigue doctors that let their patients just sleep forever. I don't ascribe to that approach at all. I think they need more rest. But just letting them sleep willy-nilly is, in my view, a bad idea because it causes circadian disruption.
So it's not like training increases the sleep debt?
Oh, no, I wouldn't say training increases the sleep debt at all, no. In fact, in young athletes, training is quite sleep-friendly. But overtraining is a different state biologically. So that's a little bit different. I think that the athletes don't get enough sleep. Yes, in the back with the hat.
Going back to the last question, the gentleman asked, getting up in the middle of the night to go to the bathroom or to have a protein shake. So you address the disruptions and you speak to like a nutritional difference to make.
I didn't. Yeah.
How disruptive is it to wake up in the middle of the night to go to the bathroom or to drink a protein?
I didn't hear that part. I don't think that's a good idea. I don't know why anyone would wake up in the middle of the night, Matt, and drink a protein shake. There must be some rationale there. But certainly, I don't think that's a good idea because your gastrointestinal tract shuts down on a circadian timing schedule. And it's not designed to efficiently metabolize food sources in the middle of the night. So I would argue that that's probably not a good idea, but you probably that's out there that it's a good idea. I don't know. I would say no. Does that answer your question, Matt? Yeah. Okay, sorry. Yeah.
Could you comment on the use of supplements for sleep, like melatonin,
Yeah, I'm going to do that. First of all, melatonin is not a sedative. And remember, you have to figure out why people aren't sleeping, okay? So if they have a problem with sedation, which is a hyperaroused state, they don't need melatonin. Okay? Melatonin is a chronobiotic, and it shifts your sleep phase, like light therapy. So we don't use it to treat insomnia or non-restorative sleep at all. And I know that people like to use melatonin for all kinds of things like better erections and all of this and that and the other thing. But I sit here, please, don't advise people to use melatonin because it doesn't work. If it's working in an individual, it's adjusting their sleep phase. And it gives them a sense of sedation and better sleep. But we don't even use it a lot in shift work because it doesn't sustain the benefit. and this goes back to your blind person question, we treat blind people with melatonin. It's the perfect model of pure circadian disruption because there's no light, right? And so we can entrain their circadian rhythm with melatonin. The problem is it wears off. And so it's not a very effective therapeutic tool. And you know, it's got a lot, it gets out there and it's used a lot, but it is not, from our point of view anyway, an effective tool. Now, if you're an athlete doing transmeridian travel, yes, we have strategies for using melatonin effectively. Problem is you have to get pharmaceutical grade melatonin, which we don't get in Canada over the counter, which is what I would recommend anyway. So light therapy becomes a very efficient, quick way to get the same effect, and it's more sustained. Light works all the time because it's what's supposed to work, right? Now, as far as valerian and all of the other things, lavender and all of these others, keep in mind from my point of view, all of those other things, except for L-tryptophan, but even so, keep in mind that you're sure they will help, but they're very, very low potency sedatives. That's all that they are. And just so you know, the recent authoritative text on the neurobiology of sleep has clearly stated that serotonin is not sedating on the brain. Okay, so that's straight from the neurobiology group at Harvard, Tom Scammell, published just a month ago in Sleep. And what we know about neurobiology is in his summary, and serotonin, and that is why clinicians find the antidepressants very variable in their effects on sleep. We don't use them for sleep at all. So tryptophan, I mean, I use a ton of tryptophan, and it really doesn't work. And I use it for people who just say they don't want to take drugs. So just, you know, I mean, you're talking to the co-chair of the National Steering Committee of Clinical Practice Guidelines for, you know, sedative hypnotic medication. And we've been through all of this. We've looked at all the drugs. And we now have a set of recommendations for clinicians. And so a lot of these supplements are based on serotonin, and, well, valerian is basically a benzodiazepine. A very low potency value is the active component. So if they work, fine. But if they don't, these people need help. More than that can give them.
Are there pharmacological agents that have been demonstrated to improve sleep architecture consistently, like phase 3 and 4 sleep?
Well, it's not that they improve sleep architecture. What we want is just to get people to sleep. It allows them this. There's a difference with the ultradian process and in the brain. That's separate from the brain's ability to sedate itself. So the GABA receptor group in the cortex is what we look at as the sedating mechanism in the brain. When you feel sleepy, that's GABA doing its thing in your brain, okay? And so the way we use that system to allow people to sleep normally. So I always say to patients, your brain wants to sleep, but your mind won't let it, so that they get the difference there. If you have an insomniac and you just give them a medication that allows the brain to sleep, it'll sleep normally usually. So, but it depends on the reason they're not getting into sleep. Is it pain? So I use a different group of drugs for people with pain. Is it mood, a high state of anxiety, more towards an anxiety disorder? Or is it simply sedation? Are these people not able to sedate themselves, which is the most common? And we have a group of non-Valium benzodiazepines that we use now that are safer, and they do the trick, yes. Yeah, with very low tolerance, low addiction, those kinds of things. You guys probably know about Ambien. That group of drugs, very effective.
I have an active use marijuana sleep.
I didn't hear you. I'll talk to you later. I know, and it works. But, you know, and there's a lot of science behind it. There's a lot of science behind cannabis and its efficacy in many different disorders, but mostly in anxiety-related disorders. And of course, insomnia is. So, I mean, of course, I can't tell you carry on, right? But but it does work for some people, and I get patients in who say they do that too. Yeah. Okay, can we go on to the cases? So the first one's 17-year-old grade 11 honors student, female volleyball player, chronic daytime fatigue. She presents with fatigue and falling asleep in class for 2 to 4 months. So this is pretty serious. Eh? She's 17, probably, grade 11 honors student. She wants to get on to university. She's going to be a whatever, And significant drop in first-term grades. And so I end up seeing these kids sometime before or after Christmas, sort of around exams with frantic parents and whatnot. Now complaining of difficulty falling asleep and waking up in the morning. She has missed school and is late a lot. So does anyone have athletes like this? Raise your hands. Like, nobody? Wow. Does anybody deal with teenagers? Raise your hands. Yeah, and you don't have athletes that are this bad? No? That's good. Okay. So I only see the really crappy ones. So this is a healthy kid, no past psychiatric history, no medications. The physical exam reveals a thin, tired-looking, normal vitals, so there's nothing dramatic here. And she's healthy, hasn't had any surgery. And what this represents is a kid who's high functioning, going through puberty, developing a delayed sleep phase. So the development of the delayed sleep phase, or becoming a night owl, is normal, and it happens around grade 7. Okay? Any of you have had teenagers start staying up later and later and later, and you're locking them in their room and all that kind of stuff. So this is normal in puberty, okay, and it has to do with growth hormone secretion and growth and whatnot. And they also, at the same time, increase their sleep need from 8 hours a night as a child to 10. So not only do they delay their sleep phase, they increase their sleep need. The end result, chronic sleep debt. And in a high-functioning individual, this becomes quite devastating. So they only show up in the office because now she can't fall asleep and she can't get up for school. So this is that high-functioning kid who was able to get up, force herself to get up, even though she was tired, for a year or so or whatever. And then all of a sudden, she could no longer do it. And it was causing a lot of problems. And then the school performance went down. And then they come into the doctor. So you guys can predict this. You can look at the kid, see if they look tired, having more injuries, those kinds of things, having more trouble with school. Ask about waking up in the morning. What's it like? It's terrible. We have to throw water on her to get her out of bed, and all that kind of stuff. And if you're hearing that, there's a problem, and it can be, and you can send them to get treatment. So what we do, it's delayed sleep phase, and basically what we do is sleep restriction. So we give them a fixed sleep schedule. Okay, get rid of the TV, the stereo, everything's out of the bedroom. Clean up their sleep hygiene. Sometimes, if it's a boy, he's drinking 3 to 4, slushies a day. We get all that sorted out, and then get them on light therapy. And these are these little, you guys have seen these lights, the SAD light. They work beautifully, and this is the kind of situation. And I'm saying to the kid, they're going, well, I do all my homework at night, because I don't have time and everything. I said, good, save a half an hour of homework in the morning, sit in front of your light, do your homework, have a breakfast, because they never eat breakfast. These delayed sleep phase kids, they don't eat breakfast. And that's a problem in and of itself. So you're starting to get them back into a normal state. They'll always be chronically sleep deprived because they just don't get enough. But it does work very well. And then what they're going to thank you for is they can fall asleep at night now. That's the big thing for them, is that they go to bed at 11 or so and they just fall asleep. And they weren't able to do that, and it drives them nuts. Yep.
Do you find that light therapy also helps in sunny places?
Well, again, it's inside outside. So the closer you get to the equator, they don't need it. You don't see it as much. But in the States, in California, there's a ton of research at Stanford going on. So they obviously have the problem, right? But they don't use light therapy, and the reason is they have light. Yep.
What type of bulb is in that?
Well, those are LEDs. And in the other big SAD lights that come out of Quebec, it's fluorescent lights that are designed some special way.
The sources for those?
It's in the thing. Yeah. So 32-year-old male professional football player, 6-month history of non-restorative sleep, daytime fatigue, and decreased exercise tolerance. So in a football player, all you're going to get from a guy like that is, geez, you know, I'm tired. I don't have the juice I used to have. I don't have the vigor. You're not going to get much more out of a guy like that because, you know, multitasking and mental function and all of those things just may not be as important to them as a lawyer or dentist or whatever. All right? So 6-month history of all of these things, waking at night with a sensation of choking, and his girlfriend says he snores like a train wreck. Pretty straightforward. Okay, there's no mystery here, okay? He's a healthy guy, but has a 40-pound weight gain, morning headache, and dry throat in the morning. These are classic. Okay, dry throat, stuffy nose, morning headache. Those are classic sleep apnea symptoms. Medications, none. Blood pressure, 138 on 90, so it's getting up there. Okay, you're starting to see the effects. Snoring is linked to hypertension, just so you know. So resistant hypertensives, we always say to the family docs, ask them if they snore, because unless it's treated, you're not taking away a causal factor. Okay? The BMI is 34, so he's obese. That's closing in on class 2 obesity, but he is a football player, so you do have to do waist circumference. More importantly, the neck circumference, which is the most accurate clinical predictor. So if you want to write anything down here, a neck circumference greater than 42 centimeters has a very high predictive, positive predictive value for obstructive sleep apnea. 42 centimeters. Yeah. So this guy's got a 48 centimeter neck, which you'd expect. He's a football player. So, you know, you're guaranteed that with that history, he's got sleep apnea. Okay, so he needs a sleep study. That's the bottom line. Is that guy needs to be either sent back to their family doctor to be referred for a sleep study, or if you have access to getting that done in your community, just get him off. And he would probably need CPAP therapy. So that's a mask unit that puts positive airway into the trachea and keeps it open. There are dental appliances and surgery that work. This is very common in big athletes, a lot more common than you think. And here's what happens. Basically, normal breathing allows for passage of airway. This is the tongue, this is the palate. In the snoring individual, there's just a lot of tissue. So the air goes in, and there's just a lot of tissue in here that vibrates. Okay? But it doesn't cause closure of the airway. In the apneic individual, there's airway closure from the tongue falling back. And so we do home monitoring. So I'll send them home with a device to do screening, and then we set them up, if they need CPAP, with this funky little device. So they go to bed with scuba gear on. Yeah, they do. Yeah, I know everybody looks at it and goes, oh my God. But if somebody's desperate enough, they'll try anything to sleep. Like your guy would go, forget it, man. I'm not sleeping with that. Yes, yes. If you have, oh, absolutely. If you have friends who snore and have sleep disruption, the first thing to do is, in Alberta anyways, you shoot them. HydroSense, which is a really good saline nasal spray, and Breathe Right strips work really well. And I always like it if they've tried that, because if that helps them, it tells me that their upper airway is a problem in all of this, and we send them off to the ENT surgeon as well, just to get a look. So that's a good way to go to start, but it usually won't get rid of the snoring. Positional control of snoring is also helpful, and if it works, the tennis ball thing is ridiculous because that just wakes them up. So I get a 30-degree foam wedge. I get them to buy a foam wedge of 30 degrees, the full length of the torso, and they just sleep on their side. And that, for a supine apneic, works really well. Yeah. So positional pillows are quite good, but not the neck ones. They have to be the torso, the length of the torso. Okay, so the last case, 44-year-old mother, 3 children, 50-pound weight gain in the last 4 years, usually winter weight gain, numerous diets, careful with caloric intake, and a regular exercise activity of 5 out of 7 days per week. She's unable to reach her goal weight and sustain weight loss. She has non-restorative sleep, daytime fatigue, and she also snores. So, you know, this is a train wreck here, you know, this poor gal. So in her past medical history, she had pregnancy-induced hypertension, diet-controlled gestational diabetes, shows she's a risk. We already know. We could have gone way back to her pregnancies and predicted what was going to happen. when her kids were these ages. Okay? One episode of postpartum depression treated successfully with psychotherapy, and a family history that's positive for major depressive disorder. So I'm trying to give you an example of the absolute worst risk profile. You couldn't get much worse than this, and easily predict the outcome. Okay? Medications she's on are none. Her BMI now is 29, which you know is overweight but not obese. The neck circumference for her is 40, and her waist circumference is 94. And in women, the waist circumference, critical cutoff, is 88 centimeters, where we consider them at risk for metabolic syndrome or pre-diabetes. Okay? So this is a woman who needs a lot of help, is basically what I'm saying. And we first have to work on getting her sleep stabilized and deal with the snoring, treat her winter depression, and the bottom line here is the mood disorder. If the mood disorder is not corrected, you can't change behavior. And in order to treat this woman, there's a lot of behavioral factors that have to be addressed. Okay? And she's starting to get very frustrated because she's doing everything right. So it's not that she's not doing it right, it ain't working, because she has so many untreated other factors that need to be addressed. Okay? So she has seasonal affective disorder and emotional eating. So this is, I see this all the time. You know, why do you eat? Well, I eat because I'm stressed. You know, this is classic. When do you eat? Late day eating. Late day eating, high calorie dense foods, emotional eating. Okay? So there's a reason they're eating, and you have to get at that. Okay? So basically we have to stabilize the mood. Light therapy, she might need antidepressants. We would evaluate whether she was that depressed or not. We would address her eating behavior, address the activity rest issues, and address her stress, because that's, at the end of the day, driving this whole process of not getting forward. She doesn't have time, and that's usually the key. Can't do that. I don't have time. So you have to give her some success so she'll make the time. And then you start moving forward. A person like that, I'll see them probably, it'll take 2 years to sort this person out. It takes a long time. That's why when the question down here about how do you sort out the athletes, that's a long answer, and it takes a long time to sort out someone who's at the far end of overtraining syndrome. Okay? So at the end of the day, what we do is recognize the problem and refer. So if there's something that's obvious, you got to refer them if you can't do it. Address the sleep hygiene, sleep schedule. Light therapy is useful. Establish appropriate goals and timelines, and then appropriate training routine for someone that fits into whatever problems they're having. So I'm just giving you general stuff here because it's a huge area and very specific and individual. Okay, so the key points, I think you got to ask this stuff. In the work that you guys do, this is very important. And if you notice a problem, start working with it. And if you can't fix it, send them on. You guys have some very good sleep people in this city. Some of the best in the world. Good. Thank you very much. Okay. Any questions? Yes.
My husband's been working with 12-hour sleep for about 20 years.
I'll repeat the question.
He's tired of sleep o'clock.
Yeah.
He's also gained like 50 pounds in that time. What happened?
20 years of 12-hour swing shifts. What can I do? Nothing.
Nothing. Get him off swing.
Yep. Yeah, he's gained weight. All of the stuff that I said, I'd predict it. This is what we see in the Calgary Police Service, and that's why I work for him, because it's a huge problem. There's nothing you can do. You're seeing the end result of 20 years of shift work. Can't do it. And at 40, very bad for you, shift work.
If we don't have any more questions, I'd just like to thank Dr. Samuel on behalf of Swiss. I'd like to present you with a small little token of appreciation. Thank you very much. Thank you. Thank you very much. Yes. Feel free to ask lots of questions. We've got lots of time here. We have some more stuff going on in the expo at the other side. Okay.
Thanks. Yep.
You mentioned I ascertained that naps are beneficial. What time of day is the best to take it? They're supposed to be less than 30 minutes.
Yep. So I'll give you the rules on napping. Okay, so this is in normal people, okay? Normal, well-rested, non-shift working people. Here's the basic rules of napping. Should be less than 30 minutes. And again, get someone to test the nap out. Teach them to nap. Have them find out, because you can cat nap and wake up spontaneously, and it might be 15, but it should be under 30 minutes. The other thing is that napping should be done 12 hours from the midpoint of your dominant sleep cycle. So in other words, if you go to bed at 11 and wake up at 7, that's 8 hours. 4 hours is 3 o'clock in the morning. You should be napping somewhere around 3 o'clock in the afternoon, because that's when your circadian low will be. If you go to bed at 11 and wake up at 7, that's 8 hours. Halfway through is 3 in the morning, and that would be 3 in the afternoon. So 12 hours from the midpoint of your sleep, you should nap, and that will be the deepest part of your circadian low in the day.
You ever see any weight gain from not eating? Part of sleeping, the person says he or she does not eat more. You know what I mean? You said usually it causes them eating. People say, well, I don't eat nothing, not much more.
So the question is, have I seen people gain weight who aren't eating more? And the answer would be not so much that they gain, it's that they actually are following a good, reasonable caloric intake and not losing. And it's beyond a plateau, because of course weight loss goes in plateaus. If you're looking at sustained weight loss, not rapid weight loss, if you're looking for healthy, sustained weight loss, I always say to people, they're going to plateau for 6 to 8 months at certain times. But I will see people who are doing everything and not losing because there are other barriers.
Any cortisol?
Yes, very much so. Yes. So a perfect example would be a person who's doing everything they can, and they're 20 pounds overweight or whatever, but they're very stressed in their job. So they're exercising and all of that. And I see a lot of these guys from the oil patch and whatnot. And it's just that they're pushing themselves so hard, their body doesn't function right. And colleagues of mine, we pin everything on cortisol, and I'm not so keen on that, but it's true, because central fat deposition is related to cortisol secretion. It's going to alter cortisol secretion, absolutely. Yes.
If you've tested someone for melatonin and they show low of circadian rhythm, what's wrong with someone when they wake up at 2 a.m. and have at that peak time of melatonin?
Okay, so
did I say cortisol? I meant melatonin.
You said melatonin. So the question is, if you've actually assessed the melatonin levels, my first question is, how did you do it? Was it serum or salivary? And then I'd ask you, how did you do it? What was the test? Was it an immunoassay? Or, so I want to know, well, what was the actual technical analysis? So was it an immunoassay? Or, so I'd want to know those things to know, because I know the validity and reliability of that stuff. So I would ask those questions. If you've tested someone and they have low melatonin, which again, you can't say they have low melatonin with salivary hormone testing. All you can do is look at ranges. So that's the first thing, okay? So if you assume that they have low melatonin, I'd first want to know, well, why would they have low melatonin if it's a young athlete? That makes no sense, like that. What's wrong with giving them melatonin in the middle of the night when they wake up? Well, what's wrong with that is that it's going to shift their sleep phase, not improve their sleep. Okay, so that's the wrong time to be dosing melatonin to shift a sleep phase. There are very specific windows where melatonin works to phase shift, but not just giving more melatonin in the middle of the night does not induce sleep. Yep, it depends on where their phase is. That's the problem, is that to accurately dose melatonin, you actually have to do salivary hormone testing in each individual, because each individual has a dim light melatonin onset, and yours is different from mine. And if we give you melatonin at the wrong time on the curve, it doesn't work. It's just so sensitive. That's the problem with melatonin. Yep?
You say the general population, the circadian rhythm is a certain way, but for some, they're night owls. And then the time zone different, maybe they're born 24 hours in DC or maybe in England.
Sorry, did you say, is that because they're born that way?
They're born in a different time zone.
Okay. So there's two factors that dictate why your sleep phase is the way it is. Like, the question is, was it because of where you were born or whatnot? And it's important to understand that the circadian clock we now know is genetically determined for individuals. And there are many factors that can affect what your sleep phase is as it's determinant. We can predict it from your parents, and then the fact of where you were born and where you reside now is an environmental factor that may in fact reinforce that sleep phase. So night owls in Calgary, I always tell them, you belong in Honolulu. If we took your brain to Honolulu, you'd be fine. But your brain's in Calgary, and they have a permanent state of jet lag. So the light therapy, is basically correcting jet lag and bringing them back to Calgary into the time zone. So that's an environmental factor, and then there's a genetic factor. Can I go on?
Does the body adjust to time zone?
Yep. Oh yeah. But
Genetic, possibly.
well, right. But we all have our own sleep phases, right? And we all have our own resistance to change in zones. So some people suffer jet lag more than others. So it really, yes, you do adjust eventually to time zones, absolutely. But some will adjust better than others. And that underlying genetic predisposition may rise up as a real problem in some people. Yes?
What's the role with alcohol and people that tend to have poor quality sleep, like waking frequently throughout the night and having difficulty falling asleep?
Yeah.
Is there like a half-life that should be considered with alcohol so that they shouldn't be 4 hours before going to bed?
I'll give you the alcohol story. So what does alcohol do to sleep? Alcohol is terrible for sleep. Okay? It improves your ability to induce sleep, and then it disrupts sleep from thereafter. Okay, so it impairs slow wave sleep, and it's a REM suppressant. So it will suppress REM, and then you get a REM rebound. So that's what the DTs and hallucinations are, withdrawal and alcoholism. So the bottom line is that if you're asking in the average North American public, is drinking alcohol at supper bad? No. No problem, because the half-life is very short for alcohol. It has first-order kinetics, so there's no problem. But if somebody has sleep disruption, they should not drink alcohol before bed, which is what they do, right? People, that's the most common drug used for sleep, induction, alcohol.
So you think you just take something one away that help you sleep?
Well, there's no question that if you have someone who comes in and has a very hyper-aroused state, very poor sleep, and they're complaining bitterly, and they drink 3 glasses of wine every night for dinner, get rid of the booze. First thing on the list.
What is the half-life?
Well, we say to people, you can't do it in terms of half-life really because it has first-order kinetics. So what we say to people is the timing of alcohol is not critical. If it's 4 hours before bedtime, it's no sweat. It's gone. But if you're drinking alcohol to sleep, not a good idea.
What about smokers?
Smokers? Okay, here's the deal on nicotine. So what about smokers? Nicotine is an extremely potent stimulant of the cortex, equivalent to caffeine. Very activating, and that's because it's cholinergic, and the REM sleep is a cholinergic phenomena, and REM sleep is actually an EEG state of waking. So I know it's sleep, but it's what we call active sleep. So the brain is very active during REM sleep. And nicotine induces that same pattern. So it's very disruptive. And so I will always say to the smokers, look, we got to get you to stop smoking at night. And I'm very gentle with smokers. So if I can get them to stop smoking at 4 p.m., I'm so happy. But you don't get them to stop because that'll kill them. Like they'll have bad insomnia. So we work at it that way. And of course, a lot of these people are waking up in the middle of the night, and why? What does it do for them? Anybody? It relaxes them. Oh yeah, smoking cessation is not something I do when I'm seeing a sleep-disturbed patient. We do that way down the road. Yeah. So I get them to count the number of cigarettes they've smoked from 4 to bedtime and start working.
How big a role is if someone is dieting under caloric restriction, if they're forcing themselves not to eat, after say 7 o'clock, and then they get a dip in their calories at night, a shot of cortisol, and it wakes them up.
To sleep well and restfully from a metabolic perspective. The question is, if you food restrict people and they stop eating at 6 or whatever, and they're caloric restricted anyway from their need, and then you have them not eat after 6, they're severely caloric restricted. And we believe that good sleep requires a snack in the evening, some small snack, so that there's something in there. That, and so I'm sure that would be incredibly disruptive to sleep.
Is there an optimum food that helps, and how far can you go with?
Yeah, we usually say for snacks, we usually say things like, just small carbohydrate snack before bedtime. So, I just say cookies or something to people, which I know is sort of taboo here. But, just a small snack. I don't know, a rice cake or something. I don't know. But something. But calorie restricting people anyway is going to disorder their sleep for sure.
You see people adapt to caffeine and still can sleep on it? Like if they're on caffeine.
Well, the adaptation to caffeine, how many of you drink caffeine and get sleepy? Yeah, that's a paradoxical response, and there's a whole bunch of reasons why that happens. So it's not that it doesn't work, it's that you've burned out the receptors. And there's adenosine factors in there too. So there's a whole host of factors. So it's not that caffeine in and of itself doesn't work, it's that it's not working on the receptor it's intended, and it's not working on the neurotransmitter that which is adenosine. If you don't have a substrate, you got nothing for caffeine to work on. So that's more likely what's going on in those individuals. Yes?
It's sort of an individual case, and maybe a little different than what we covered today, but my girlfriend has this problem where she'll wake up in the middle of the night and just sort of almost like totally in fear without reason, and it's affected her cognitive performance and athletic performance in the gym. Strength in all our major lifts is down. Easily gain weight. From what I've read, it could be a nightmare.
Yep, so you're describing a classic parasomnia. Classic, and it would be either a nightmare or a night terror. And I would ask, and the difference is nightmares occur in REM sleep, and night terrors occur in stages 3 and 4, and that's probably a night terror. If it's a state of fright, a very hyper-aroused state where you can't communicate with her, and you roll her over and put her down and she goes right back to sleep.
Well, sometimes even if she'll be making noise and like laying around, and if I shake her, she's trying to wake, and then she does wake up, she's freaking out, and
she's gone. Okay, so this is a classic night terror. I'm trying to decide whether to scare you or not. But those are the people who have basically what we call arousal disorders, and the ones that I see have slit their wrists in the middle of the night, jumped out windows, pretty bad stuff. It's amazing what people can do in that state, but that's just a simple night terror, okay? And but it's an example of these dramatic things you see. I saw one on the front page of the newspaper the other day, a woman who sleepwalks and has sex with people, okay? The murder defense was used here in Ontario a number of years back. The Parks case was a sleepwalking case, and it was successfully used. So that's an example. Obviously, your girlfriend's not going to do that. But it's and usually the factor underlying they'll get very intense, right? You'll go through periods where they aren't happening and then they happen. Usually it's very stress related. Sleep deprivation and drugs are the 3 top causes for an increased frequency. And she probably sleptwalked as a kid or something like that, or had night terrors as a kid. But it's treatable. You can get help for those things. Because that I would say she needs to see a sleep physician because it's affecting her performance. That's not good. That's bad. Behind there?
You're saying for a cat nap, 30 minutes is good. But if you went to the longer end of a cat nap, is there such a thing, an hour and a half, 2 hours? Would you be okay? Or?
Okay, so there's 2 factors here when it comes to napping, and the question was, as I was quite adamant, 30 minutes. That's it, right? And I told you why, because you don't want to go into stages 3 and 4 of sleep, right? But if you're sleep deprived, you need sleep.
You may have 5 hours sleep, right?
Right, and so but the answer will be you'll sleep 2 hours and you'll wake up and feel good. And if that doesn't happen, you're sleeping too much. So that's the way you manage that. Yes?
I have two questions. One is concerning patients with chronic pain, especially with injured low back pain patients and disrupted sleep. And the other one is concerning brain trauma, people who have brain trauma and chronic fatigue due to accident. In the first case, do you treat the sleep patterns, or like in your opinion, what was your first reflex to go to treating someone who has sleep disorders due to pain?
Okay, so the pain-sleep factor, and this is a great example, chronic back pain. Okay, so the chronic pain clinic at the Calgary Regional Health Authority will send patients over to me. Okay, and what's absolutely fundamentally critical is that their pain is managed as well as it can be. If that is not happening, there is absolutely nothing a sleep specialist can do for these people, because the pain has to be controlled. Now, of course, you can't get rid of it, right? But what you can do is get it to a level where we can do our little magic trick, and usually, without a question, it's ruling out primary sleep disorders and using drugs to get them sedated so they sleep through their pain. Okay? So that's a very quick answer. Is what we would do, okay? Does that answer the question? Okay, second question.
Concerning brain trauma, I see patients with chronic fatigue during the day and having trouble functioning with symptoms like concentration, distraction control, cognitive actions that have become much more difficult. Not only because the brain is injured, but the neurological information and the integration of the information is become more and more difficult. All the fatigue that comes with that. Is there any research or protocols for these type of
So obviously it depends on the brain trauma, because you have to know the location of the injury and what damage has been done. Okay, but let's say it's a global injury, and they had a concussive injury or whatever, and they're recovering from it, and they can come in two ways: insomnia, or three ways: non-restorative sleep or excessive daytime sleepiness. So we see the excessive daytime sleepiness because they literally aren't functioning, and we will go through a proper evaluation, and if they usually end up having what we call CNS hypersomnolence, which is a global idiopathic term for we don't know what the hell's going on. We will use stimulants in them, okay? And stimulants such as modafinil is the one now, and it's a glutamine receptor agonist that we use in treating narcolepsy. Because at the end of the day, these people would need to function. And if you can give them something like that gives them good alertness, good concentration, it usually will mitigate all of the symptoms that you said, so you can get on with doing the other work. If they have insomnia, and I see a number of brain-injured people with insomnia, it's very difficult. They're very difficult patients to treat. The behavioral stuff doesn't necessarily work because they have anatomical injuries to brain structures that likely are integrated in the sleep mechanism.